speakers today, one of whom is joining us via Zoom. Via Zoom we have Erica Clark-Jones, who is the CEO of the Alcohol, Drug, and Mental Health Board of Franklin County. A Columbus native, Erica's experience spans across public health, public affairs, public policy, constituent relations, and engagement, and strategy development and management. Erica's career includes 19 years in the mayor's office, including time as deputy director of the Community Relations Commission, policy director, and director of the Office of Homeless Advocacy. Additionally, Erica led the Southern Gateway Initiative to improve neighborhood conditions on Columbus's South Side. Throughout her career, she has demonstrated a track record of success, most notably by collaborating with a coalition of public, private, nonprofit, and community stakeholders responsible for reducing infant deaths by 23% in Franklin County. And then here in the room with us, we have Jonathan Thomas. Jonathan Thomas joined the ADAMH team in January of 2015. In his role of Vice President, Planning and Evaluation, Jonathan is responsible for leading ADAMH's planning and evaluation functions. He began his career working at an ADAMH-funded agency that focused on youth, residential, and treatment foster care programs. Jonathan then went on to learn from additional experiences with public policy, strategic planning, program monitoring, and evaluation in positions with the Ohio Department of Health and Ohio State's Harding Hospital. Jonathan completed studies in both psychology and social work before earning his master's degree in public policy and management from the John Glenn College of Public Affairs at The Ohio State University. Jonathan is excited about the opportunity to lead ADAMH's planning and evaluation efforts and support the ADAMH Network's collective efforts to better meet the needs of our consumers and the community at large. Thank you both for joining us.
What an honor to at least be able to be with you, even though it's virtual today. I had every intention of being there, but unfortunately I'm under the weather today and don't want to take any chances. So thank you, not only for welcoming my colleague and I, Jonathan Thomas, to your meeting today. I have a tremendous amount of respect for the Columbus Rotary. In my time in public service, I think I've been before you all maybe 2 or 3 times over like 15 years. And it's always a big deal because you all are really keepers of the faith and you hold folks accountable on behalf of the voters and all the residents here in Central Ohio. So just thank you for all the things that you do. I also want to, I know we've had an introduction of my colleague, Mr. Jonathan Thomas, Vice President of Planning and Evaluation, and Ms. Jill Frost. Jill Frost has been with us a really long time, helping make sure ADAMH articulates the message to the community, and then, in turn, gives us feedback about what the community is seeing and hearing over a decade. And so I want to thank Jill. And Jonathan has just been, I started with ADAMH about 2 years ago, and he and I immediately bonded on the project we're going to talk about today. And I'm honored just to be on the team, quite frankly, and to do my part to get this really important project off the ground at a pivotal time in our community. So without further ado, I'll just jump right in. Don't want to cause any more delay, but I'll jump right in to why we're here today and to thank you again. 2 years ago, actually I think it was last year, we went to the voters of Central Ohio and we requested that our annual millage increase by 0.65, and the levy passed about 70 to 30, about 70% for and 30% against, but it was really a vote of confidence for ADAMH. And one of the reasons this position at ADAMH attracted me was because ADAMH has such a strong reputation here in Central Ohio. They do what they say they're going to do. And us being really the backbone of the behavioral health safety net for those that are insured or uninsured for it is a really important role that we have. And this crisis center is where we're going next. And quite frankly, really thinking about how to increase access across the board in an equitable way to anyone who needs behavioral health services is our key focus. And so I'll just kick it off with a couple of important points as we set the stage or really frame the need for what we are calling, at least until it's titled something different, the Franklin County Mental Health and Addiction Crisis Center. And so, Jonathan, I'm not sure if you have control of the slides, but when we started planning for the Crisis Center, a few figures were very impactful early on. And given the fact that 20% of all of Franklin County residents, and now, by the way, these numbers are pre-pandemic. So at the time when we were planning, 20% of Franklin County's residents, our projections would experience a mental illness in any given year. Now, Franklin County was seeing nearly 30,000 episodes for adults a year, with 900 individuals needing transportation to emergency departments due to a need for medical clearance, and we had forecasted a demand growth of 23% in the next 10 years. So 30,000 episodes a year, 900 individuals needing transport, and we project that to grow 23% over the next 10 years. To highlight a connection to what was shown a few moments ago, earlier in the slide, the community, we did a community needs assessment last year, and Jonathan really led that work across the community, and it highlighted gaps in access to care. And some of you note that crisis service in our community needs assessment, crisis services were not called out prominently. And for us, while most individuals can access crisis services right now, 24/7 in our community, they are being delivered in a place that it probably shouldn't be, and that's our hospital emergency room. In fact, approximately 70% right now of all crisis encounters each year are treated in hospitals versus in community-based settings, where the evidence is clear that care is more tailored and outcomes are better for individuals when they're serviced in a community setting. So we still have the right models, right, or our capacity isn't quite where we want it to be to meet the demand in our community-based system. Next slide, please. And this is a yes, because that's what we're working on. So we have benefited greatly, and I can't underscore that enough, from a diverse stakeholder group that has been informing our planning on the new crisis center from the beginning. The PCES group and several folks are on that board, including all of our adult serving hospitals, the Columbus Foundation, the Columbus Medical Association, and so many other community partners came together and discussed the challenges in our community. And I see a note from some of our online participants that the slides are indeed not advancing at this time. But I can't thank enough all of the partners that came together. That included law enforcement, it included advocacy organizations, and individuals and families with lived experience. And so it is truly a community-wide project. And if there's nothing else I want to convey from that is this wasn't just ADAMH. It was everyone coming together to say, how can we do this better? How can we attend to the needs of our community and crisis episodes in a way that is dignified, makes sense, it's efficient, and there's a cost benefit to this type of care, and people are getting the care they need at the right time. And that, quite frankly, is what led to the planning on this community-wide project that ADAMH is thrilled to be leading. At this point, I'm going to turn it over to Jonathan, one, because he's in the room. He can kind of advance the slides there and talk through this. So Jonathan, this is really a culmination of several years of work on your behalf. And of course, I thank you all the time, but it's always great to thank you publicly for your commitment to this project. Jonathan?
Thank you, Erica. Part of the community efforts that Erica was referencing, and she mentioned the Psychiatric Crisis Emergency System Task Force. That group was co-convened by ADAMH, the Central Ohio Hospital Council, as well as the Columbus Foundation. We hosted that, brought together 36 or so community partners to come together and talk about how do we right-size some of the issues in our community to address crisis care. One of their key recommendations was a crisis center. They talked about it in a hub and spoke kind of design. Like a crisis center can be at the center, but you've got to have lots of other connections. And the ADAMH board a few years ago took that recommendation and said, well, we can all say a crisis center. And if I went around the room and asked all of you, what's a crisis center mean to you? Well, we'll have some commonalities. I don't know if we would all have enough alignment in our detail to go build that thing. So we formed a steering committee, brought together people focused exclusively on fleshing out what would a crisis center look like. And a lot of what I'm going to present today is going to be getting into the details of what we came to and what we're working towards building. But I want to make sure we always put it in context of there are actually two other paralleled efforts the board's undertaking right now in the crisis space. And we see these as three kind of prongs to our crisis continuum. So one is the fact that 988 is being rolled out as the national number for suicide and behavioral health crises. It's actually already active on most of your cell phones right now, whether you know it or not, it'll work. But the big national rollout and advertising for that will begin in July of this year. So we want to see the call center infrastructure for Central Ohio also be right sized so we can handle the increased volume we anticipate will come with 988. Then we have mobile response. Mobile response is getting a lot of attention right now, but mostly co-responder models. And when we say co-responder, we mean putting a behavioral health specialist or a clinician with a first responder, whether that's law enforcement or EMS. And those are vital responses that are trying to more, thoughtfully use public safety resources. But the ADAMH board sees that continuum going even further. We actually should have community-based teams that have individuals with lived experiences, certified peers and clinicians that can also respond when you don't need any public safety resources. So we're working on efforts to pilot those teams this year as well. And then we have the Crisis Center, which is the big project, and that's what the handout in front of you is about. And that's what the remaining slides will be about today. I lost my slides. One second.
Yeah.
We'll get those right back.
No, they're still not seeing them on the screen.
Oh, they're not. That screen share's not working. So one thing I'll say is I could just go and talk and answer questions. As Erica and many of my colleagues at the board know, and Jill's being able to see some of this as well, I have done everything from 3-minute, believe it or not, to 3-hour presentations on the Crisis Center alone. So today you're going to get something much closer to that 3-minute version than the 3 hours. But I will note there is a website link that is, or a website address that's on that fact sheet. Anything I'm going to say or talk about, the source of that information and drill down information is all available out there, and we're also always available not only in the moment today to answer questions, but you can feel free to send us follow-up questions. So the Crisis Center is a building. It'll be a new building that'll be built to serve Franklin County, and so we always want to make sure you're aware of where it's being located. It's being located on the West Edge area. That was a strategic selection of this parcel that we can zoom in on and show you if you know where Franklin County Children's Services is on West Mound, right down the road from Old Cooper Stadium.
Just step forward. Step forward.
I can't tap dance. So it's but the selection was based on an analysis of the data we had available. So we looked at things like who's currently presenting an emergency department in crisis and where are their resident zip codes. We looked at EMS and police runs. Where are those taking place? And we looked at the counters that were currently going to our community-based crisis provider. We also wanted to be mindful of access. So that's access for first responders, so being close to the freeway, but also public access. So is it on a bus line? And so we took all these factors into consideration, and the parcel on Harmon Avenue really checked all of the boxes. It's centrally located where we see a lot of demand in our community, but it does have close access to freeway as well as the bus, and it's close to emergency departments when someone would need a transport. Next slide, please.
We can't win today.
That's all right. Keeps me on my toes. I like it. So the Crisis Center. I had mentioned if I asked you all what you would picture of the Crisis Center, you might have some things the same and some different. When we talk about it, the main thing we focus on is 3 levels of care. So the Crisis Center will have 3 different service units, if you will. So when someone presents, the level of need might be different. So we have a 24/7 walk-in clinic, and those are for like less intense or less acute encounters of crisis. Perhaps someone's out of medication and they can't get in to see their provider or their prescriber until Thursday when it's a Saturday. Well, if we wait till Thursday, we could have a very intense or a very acute crisis. But if there's somewhere they could go, get some immediate support, talk to a peer, maybe get a bridge prescription, confirm that appointment, then we can avoid some of these crises from becoming more intense. So those are the lower acuity walk-in encounters. Then you have 23 observation. That in our business, in our industry, that's the core of crisis stabilization. It's 23 hours because you're allowed to have someone in that level of care for up to 23 hours. If it goes 24, then they're technically inpatient, or they're staying overnight. So they're offering 24/7, looking for 18-hour kind of length of stays. But this is the immediate stabilization of somebody to figure out what is it they need, can we get them stabilized, and can we get them linked to that next level of care, whatever the next level of care is. And then an inpatient unit. Now, we're not trying to build enough capacity at the crisis center for all of the inpatient psychiatric needs. Central Ohio is actually pretty fortunate that we have a lot of inpatient psychiatric providers between our hospital systems and some of our freestanding hospitals. But what can happen at a facility like this is someone can get into the observation unit, they're there for that 18, 19, 20 hours, you realize they need to be hospitalized. And you can't always get somebody right into a hospital bed as soon as you want them. Or as soon as you identify the need for them to transition, but we don't want them to stay in the observation unit because the goal is the observation unit's never full. It's never on divert where someone can't come in because this needs to be 24/7 accessible. So by having a smaller inpatient unit on site, in those instances where we can't get somebody linked to a community-based bed, we actually have a unit on site we can move them to without jeopardizing the capacity or the flow of individuals who might need to come into observation care. The other services that you see listed here, they're not levels of care, but they're services we're integrating regardless of the level of care the individuals would be in. So if you present with substance use disorder and you need treatment services, withdrawal management, detox, medication-assisted treatment, you can receive that at any of the 3 levels of care. If you have some medical concerns that need to also be addressed, if it's not, advanced life-saving medical services, we're integrating what we were calling like an urgent care level of medical services on site, so you would have access to those, as well as family support services, linkage to community-based care, and then meeting any of the pharmaceutical needs of individuals that when they're in these units or if they leave with a small set of prescriptions before they can get to see their next outpatient provider. So the project as a whole has been estimated to be a $50 million all-in capital project. So those are the construction costs and everything that comes with that. We're very fortunate to have not only the strong support of all of the partners who've helped us plan, but also all the partners that are coming together and helping make it a reality on the capital side. So we're currently at $44.5 million committed of the 50. You can see the range of commitments there from the state, the county, the city. We've also had our adult serving hospital systems. Recently, we've announced $4 million of philanthropic support, and we have a capital campaign that's underway to raise the remaining funds for the $50 million for this project. There's a list of milestones here. Again, there's a lot more information on these on our website, but the main thing that's been happening this year is we're in 22. The main thing that happened throughout 21 was the steering committee finalized all of its recommendations. So the service mix, the location, all of those things were all finalized in January of 21. So we spent most of last year building out the implementation team who can help us do this. I believe the ADAMH board does a lot of things, but believe it or not, building buildings typically is not one of them. So we've been going through a process, bringing on an owner's rep, bringing on architects and engineers, bringing on a construction manager. We've also identified the presumptive operator. So this is going to be a new model of delivering crisis care. We did a competitive RFP. We were fortunate to have RI International, who manages facilities in several states around the country and also recently was awarded a contract in Dayton by the Montgomery County Board, coming into our community who has expertise in this service delivery model. So we've really been rounding that team out, and now we're in the schematic design phase and really looking forward to the next steps, which include groundbreaking on the project, which is targeted for this summer, which should put us on target for the services to begin being delivered in 2024. So like I said, you didn't get the 3-hour version, you didn't get the 3-minute version, but you got something in between there, more resources in front of you. If you have any questions, I would be more than happy to first repeat the questions, as the sign tells me to, and then offer answers or at least responses to those. Yeah.
As part of the COVID relief package, did your organization was able to get any funding through that through either the state or federal government?
So the question is whether or not we've received any funding for this project through some of the COVID relief money that's been made available to state or local. I will say we are aware of those opportunities, and we are in conversations with our partners, city, county, federal partners, looking at those opportunities. But as it stands today, none of those COVID relief funds specifically have been targeted to this project.
I'm intrigued by the notion of community-based support people. Could you give a description of who might that be? Are these volunteer-based? Did you train them?
Absolutely. So the questions regarding kind of what I meant when I talked about those community-based supports and linking individuals to community-based supports, I believe. I hope I'm understanding the question correctly.
And it sounded like you would have somebody there to support the person.
Absolutely. So one of the things, so you'll hear us and you'll read in some of our materials talking about what we call a warm handoff. So one of the concepts behind this service delivery model is while someone's there, they're receiving the immediate mental health and addiction services they need to resolve the crisis, but you're probably identifying a range of needs or supports that this person could benefit from. And so we're hoping to make those, identify those issues through an assessment and then make those connections. How those connections get made can actually vary quite a bit, but we're building capacity on site where community-based partners, whether that's community-based mental health providers, whether that's someone from the community shelter board, whether there are other social services in the community, could actually come on site, have some dedicated office space, and they could meet with these individuals or their families before they're discharged. A very common practice is you get your first needs met, someone knows you need more, fill in the blank of whatever that is, and you're left with information. Call this, look here, pick a provider, go to this website. We would like for the person leaving to interact with those agencies and individuals before they're discharged. Best case scenario, they come on site and you meet with them. Worst case would be something more like telehealth consultation, but it is a warm connection to that agency before discharge. Yeah.
I've heard quite frequently about how workforce is really a significant challenge, not so much the facilities, but workforce. Could you speak a little bit more to that?
Yes, the question is for me to speak more to how to address the workforce issues.
Behavioral health workforce.
Yeah, no, it's a great question. We are aware of it. It was highlighted not only in our needs assessment, but also in our strategic plan that's underway right now is how we can be supportive of addressing the workforce issues. There's a lot of initiatives. The board's working through our provider agency. We're working with universities and colleges on, increasing the pipeline of the workforce, and the state has initiatives as well. One of the things I'll say that's unique to the approach to the Crisis Center project, and one of the reasons that we found RI International's proposal to be very favorable, is the integration of peers or individuals with lived experiences into the workforce. So a lot of times when we talk about the workforce challenges, you're talking about people with very specific credentials, and some of those are advanced degree credentials. But what we're seeing around the country is that if you can integrate individuals with lived experiences who are certified peers, so there still is a formal process to that credential, but it doesn't require an advanced degree, having someone with a lived experience in that crisis setting is increasing outcomes. It's decreasing, restraints and seclusion. It's decreasing injuries. It's decreasing length of stay. It's decreasing readmission rates. And so in RI's model, about 50% of their workforce is actually individuals with lived experiences. And nationally, they're the largest certifier of peers in the country. And so we think that's going to help create what we believe is beneficial in terms of its evidence-based, and it showed as a promising practice of a different workforce that can meet the needs, but they also have a track record of replicating it in several states. So while I can't sit here and say that we believe that will solve all the workforce strains, but we're very energized by the fact that having this approach to integrating peers and RI with their experience will give us more opportunities to fill in that workforce without tapping into those traditional pools that are very depleted right now. Yeah.
For the detox, is that for alcohol and narcotics?
Yeah, so there would be any substance that they are detoxing from. Now, to the extent their detox could be managed at the crisis center will depend on the complexity and also the substances. But what we're trying to do, especially for our first responders, is say, this is a no wrong door 24/7, always bring them here. Now, will they stay here all the way through detoxification? Possibly not. But the immediate stabilization, the identification of those needs, and then the crisis center staff can link them to the next level of care, which could be going to a facility that specializes in longer term, subacute detox, as opposed to medication assisted treatment, which is really where a lot of detox services are transitioning to right now.
And then, so do they have to be, can anybody just walk in and receive go into detox, or do they need to be taken in by EMS or another referral agency?
Yeah, and I forgot to repeat your first question. Your first question was regarding detox from my answer. The second one is, do they have to be brought by someone, EMS, in order to receive detox or other services, or can they come in on their own? mode of arrival can be anything. So whether it's someone that walks in, whether they're brought in by a loved one, whether it's a community-based provider that realizes they're escalating and need more services, or a first responder. But there will be a separate entrance for first responders, and there will be a separate entrance for the public, and they'll all go through the same intake and triage process.
One more?
Last question, yes.
We've all read about the effect of the pandemic on mental health in this country. Some of us probably experienced it one way or another. Could you just comment on that from the Franklin County perspective?
Yeah, so the question is for a comment on the impacts of the COVID-19, the pandemic, on kind of behavioral health care in general. And I will offer brief comments on it, and some of my clinical colleagues could definitely bring more to that conversation than I can. But we've seen it exacerbating a lot of issues. So we're aware, whether it's from youth through adults, we're seeing increased issues, whether it's with substances, whether it's dealing with the stress, the trauma that has come with the pandemic itself, the isolation, the trauma of loss that has been escalated during the pandemic. So we know those issues are occurring, and it's one of the reasons I believe Erica mentioned when we looked at 2 years ago doing our volume estimates for the crisis center, and we had that 23% demand growth that we were projecting. It was pre-pandemic. The data haven't been refreshed enough for us to kind of redo those numbers, but I think everyone is seeing that the need for this type of facility and the need for increased investment in behavioral health care is something that's hitting all of us, and it's hitting all sectors beyond those that are just traditionally in the healthcare process. So I know that probably wasn't an answer to the question, but it was a response, and it was definitely a genuine one.
I'd just like to weigh in before we conclude, and I love the question, and everyone's asking it right now. The behavioral health space, we're having a moment. It's a redefining moment, frankly, that forces individuals to talk about certain conditions or symptoms that they may be having and to seek treatment. And we want that. We want more people to seek treatment no matter what your insurance status is, your age, your race, where you live in Franklin County. And so we think bringing the crisis center online, rolling out 988, as a highly accessible phone number for anyone to call and reach out and ask questions and get connected. This is a really important time for us to maximize this moment. If you've been reading the papers even over the last week, there's a lot of talk within law enforcement about how to redefine a response to a call that comes in that's related to behavioral health. And do we respond with a law enforcement officer, or do we bring in mental health professionals? ADAMH is all for getting that right response. And if it calls for a behavioral health specialist, we want to support a model that makes sure people are getting the care they need at that pivotal moment, and not necessarily bring in a different type of response that perhaps generates a different type of reaction to that responder. And so I think it's great that everyone is talking more about mental health, mental illness, and increased substance use, and then what to do about it and who to reach out to for help. So we think this is a great time for us to redefine what you do and what the protocols are in Central Ohio, and this crisis center will help with that.
Thank you all very much.
Thank you.
Wow, that's pretty cool. Thank you to the whole ADAM team for all that you're doing. And how about the new phone number, 988? Is that what it was? Hadn't heard about that. Something you learned at Rotary probably today. Thank you all for coming to Rotary. That concludes our meeting. All right.